All right, so very briefly, my name is Stephanie Birch-Murbach. I am the program manager for the California Department of Public Health Wastewater Surveillance Team, also known as Cal Sewers Team. And I have the pleasure of helping to kick off our afternoon session. I'll also be helping to facilitate and do all the timekeeping for this afternoon session. But just to make sure you're all in the right room, our objective for today is to examine how levels of surveillance, whether it be geographic scope, sampling frequency, number of targets, has evolved. And we want to weigh the benefits, challenges, and trade-offs of various strategies. And so I'm going to introduce our moderator, and she's going to kick things off for us. So I'm very pleased to introduce Gabriela Iglesias-Mendoza, who holds a master's in organizational leadership with a focus in project management and a bachelor's in molecular and microbiology. And she currently serves as the coordinator for the California National Wastewater Surveillance Systems Center of Excellence. I'm saying what? Did I say California? I'm so sorry. Colorado. I I I am actually, no, I'm very sorry, Colorado. Um, which would have been really silly to say then she also works for the Colorado Department of Public Health and Environment. So anyway, very sorry about that, but Colorado, I hand it over to you. Yes.
I'm gonna move this over here. All right. How's everyone doing post lunch? Good. Awesome. And the sun has come out a little bit, so let's get started. All right. So I wanted to introduce our panelists, just a brief introduction, and then they're going to go into their own presentations. We have Ariel Christensen. She's an environmental epidemiologist at North Carolina Department of Health and Human Services and currently serves as the deputy director of the North Carolina Wastewater Monitoring Network. We have Likhita Duggirala. She is the lead of the wastewater surveillance epidemiologist, serves as the lead as a wastewater surveillance epidemiologist for the state of Nebraska and is responsible for designing, developing, and implementing all epidemiological activities within the wastewater surveillance program. Next, we have Rebecca Schneider. She is a staff analyst at the Houston Health Department and involved in the development, improvement, and the data to action process within the wastewater surveillance program. And then we have Angela Rabe. She is the wastewater epidemiologist for the California Department of Public Health, and she serves as the Center of Excellence Coordinator for the CDPH Surveillance of Wastewater Program. All right, so I'll go ahead and allow the presenters to go into their presentations. So,
I think we have slides. There you go.
mhm.
Thank you. Yeah, thank you so much, everyone, for being here in the room and virtually. I'm really excited to see so many shining faces that are excited about wastewater, especially given the context of everything that's happening. It's just really nice to be here with all of you in person. So, yeah, I wanted to just give a little bit of a background about our North Carolina Wastewater Monitoring Network, just to frame up some of the conversations we're going to have today. And I'm now moved to the director of our North Carolina Wastewater Monitoring Network role and helping direct our Center of Excellence as well. How do we? Oh, okay. I'll just say next slide. Thanks, Cody. Thanks. All right, perfect. Next slide. So like I just mentioned, in August of 2024, CDC designated us in North Carolina as another center of excellence, joining the ranks of some really great team members here from Houston and California and Colorado and New York and Wisconsin. So we're really excited for that official designation, representing really the southeastern part of the United States, although we work with many of you in the room and many of other folks across the nation. And our formal partnerships for our Center of Excellence are our academic partner is UNC Chapel Hill, which we have some folks here from UNC Chapel Hill joining us. And then our utility partner is OWASA, which is our Orange County Sewage Authority. Next slide. In North Carolina, we monitor regularly for 4 different respiratory pathogens across our 35 sites in across our state. So you can see we really tried to make sure that we had good geographic representation across North Carolina, which is a pretty diverse state. It takes about 8 hours to drive from one side to the other, so it's very large. So we were monitoring for SARS-CoV-2, influenza A, B. We're also doing responsive subtyping for H1, H3, and H5. And then we're also doing respiratory syncytial virus at all of those sites. Additional pathogens that we're doing, we've been doing Mpox surveillance, including subtyping for clade 1 and clade 2. We've been doing some of that work since 2023. And then we are also working on measles. Next slide. I wanted to just give a little bit of an overview of some of the things that we've been able to accomplish in our program for the past year. So like I was talking about, we've been able to look at 5 different pathogens across those 35 sites. Our wastewater treatment plant partners have helped us, and our lab partners have helped us analyze over 3,600 samples in this past year, which has been incredible. We also are representing about 3 million people in North Carolina out of our 10 million population, and that goes across 36 of our 100 counties. Those sewer sheds also include 42 emergency departments, as well as 329 local or long-term care facilities, and about 800 schools. So just giving you a little bit of who's all represented in our network. Next slide. I wanted to just make sure I had the opportunity to talk a little bit about the importance of wastewater data in North Carolina, and really how much it's been elevated as something that the public has been using. So our dashboard includes our respiratory summary dashboard, which includes 3 key metrics. So emergency department visits, hospitalizations, and wastewater monitoring. They've been our 3 key metrics since about 2020. So really, we've been able to raise wastewater monitoring as one of those decision-making tools that we've been using. And our dashboard for our summary page, which includes wastewater data, is our most viewed dashboard in all of our DHHS site. So we have a lot of people who are coming to those sites to get a snapshot of, a pulse check of what's going on with respiratory pathogens. And then our wastewater dashboard, which includes site-specific data, is our second most viewed dashboard in all of our DHHS sites. So we're really proud of the work that we've been able to do and just how many folks are really using this data every day. So next slide. We also, like I mentioned before, are doing Mpox surveillance at select sites. Recently, we had an Mpox clade 1 detection at one of our sites in North Carolina, and we were able to work with CDC and the local health department to do some public messaging about the findings that we were seeing, and really just try and encourage people to get vaccinated, to understand that Mpox is still out there as a concern. We are, making sure that we're thinking about our most vulnerable populations and the populations we think might be at risk. And I just think overall that we were able to use the information to inform the public. So I think you can click next and it will show you a couple of, and click it one more time. Sorry, they're kind of building slides. So our local health director really took a lot of the lead in communication with the local media and explained really well just what this means and what this doesn't mean. And we didn't end up finding any cases associated with this, but I think it was a really good exercise for us to work with the local hospitals and kind of elevate surveillance, be able to do some additional testing. So just wanted to include that example. Next slide. And then just wanted to end on a moment from sharing some voices from our community. So recently we had some lab struggles and we hadn't updated the data on the dashboard, and we got a lot of interest from the public. Hey, where's the data? Which was actually very validating for us, knowing that people are using the data. And one of the persons who reached out to us really explained how, as an immunocompromised person, they were using the data to make sure that they were scheduling for their whole family when to go to non-urgent doctor's appointments or dentist appointments and whether or not to attend group activities. So I thought that was just a really good example of like day to day how people are using wastewater data in North Carolina for decision making. And then our local health departments, of course, like are really using this information to inform health messaging, like for example, the MPOX situation that we were just dealing with. So I'll end there and just thank you all so much for talking with us more about wastewater surveillance.
Hey everyone, good afternoon. So I'm Likhita, I'm from Nebraska, and today I'm here to share about how we approached to determine what levels of wastewater surveillance, is effective in Nebraska. How do we determine what is not, how many sites are not too much or how many are adequate? I think that's an important question to actually manage our resources and yet effectively use the data, be able to use the data. Okay, next slide, please. Thank you. So we initially started wastewater surveillance in Nebraska, like we piloted in December 2021. And as we moved from the pilot to the full implementation phase, we realized that for determining when and where to sample, we really needed to know, for the first thing we needed to know is the local context, because every state is different. There is no one size that fits all. I'm not talking just in terms of geography, but like how the population is distributed, who makes the decisions on the ground, how is your public health system structured. So there are so many things we have to evaluate first before even jumping into how we have to design the system. And the next thing is, especially in Nebraska, it has a really unique public health landscape. And so the next slide, please. So we determined, like, first thing we asked is like where to sample, how to sample, what are the population we are serving and all these stuff. But the first thing we looked into is the geographical distribution of population. This is very important for us because, okay, to give you a context, we are fairly a very large state. Like in terms of area, I'm talking about top 16 in the United States, but we have the population of only 2 million people. So, okay, I'm sorry. Is it okay now? Okay. So to give you a context of proportions between the land and the population, like we are the size of city of Chicago, the population of city of Chicago, but we are 330 times larger. So this gives us unique problems like the population coverage. You can't have maybe 50 sites or 100 sites to really cover all the population. So we had to have like a strategic plan to actually be effectively have few sites, but yet have actionable data coming in. And if you see this map, this is the map of the population density by each county. And as you can see, most of our population is concentrated on the eastern Nebraska, and which is the Lincoln and Omaha metropolitan area. So 45% of our population is actually in this area. And the rest of the approximately 45–50% of the population is distributed across the state. We wanted to have a system which gives us geographical equity, because we already have challenges with these. Most of this, the rest of the state is rural, and we already do not have enough clinical data. And we don't know, wastewater is something that can help step up in these situations and serve as an additional tool or sometimes the only tool for these areas. Next slide, please. So that is the first thing. And the second thing is the public health structure of Nebraska. So we are a decentralized we have a decentralized public health model. So we have 19 local health departments, and we wanted to make sure that site selection will ensure every local health department sees value in the system. Because for local buy-in, it is important that they see themselves in the data. If you want to ask them or encourage them to use this data, the first thing is their communities have to be reflected in these data. That's when you can expect the action to be taken. Because as a state, we are here to support, but because it's a decentralized system, most of the action, like, they talking to the communities, dealing with the outbreaks, or taking any action using this data happens at the local level. So it is important we involve them as much as possible. Next slide, please. Okay, thank you. So we came up with a model, surveillance model, like a sentinel surveillance model. I know from last year, we have been talking about right sizing and, scaling down the sites and everything. But right from the start, from 2021, our plan was to have a sentinel surveillance model. We have limited resources. We wanted to use it as strategically as possible. And our, so with this geographical distribution we have, and also with the public health structure we have, we decided to go ahead with like having at least one site, one community wastewater treatment plant in each local health department. So we currently have 17 wastewater treatment facilities and 2 upstream sites. So this covers 15 out of 19 local health departments so far. We are still continuing to try to fill up at least one site in each other local health department. And this covers approximately 70% of Nebraska's population. So the way we selected sites, it's not some random selection, but we tried to have the population centers in these rural areas also, because these are the places where a lot of hassle happens. Like people come in and out of these cities, they come for like work, school, healthcare, recreation. And our focus for the state of Nebraska is the infectious disease surveillance for wastewater. So with infectious diseases, one thing we know is it's like throwing a pebble into a water. It has a rippling effect. The same thing with infectious diseases. Usually what you see in these population centers in these regions, will help you to understand the broader regional transmission patterns in those regions. So we selected these cities from all over the state, and also this gives at least, I know in our Panhandle region that is on the west, we have like 2 sites, and Lincoln and Omaha, we have 2 sites. So we tried at least one site, but to have a better coverage, sometimes if there's more population or more area, we tried to go for more than one. And this also helps for the LHDs, because when the data is locally relevant, LHDs are like, more likely to trust it, own it, and act on it. In terms of like how often we sample, we currently sample 2 times each week. We went back and forth on this, especially with our rural sites. It's really difficult. The reason I say rural sites is to give you an understanding. These wastewater treatment plants are sometimes the whole show is run by one person. It's not like they don't want to help you. They don't want to help their communities. It's just that they do not have the bandwidth to do that. They genuinely do not have the bandwidth to do that. So we, at one point, considered one sample. But I know there was a standard recommendation, and many research papers said 2 to 3 samples per week proved more effective. So to just strike a balance between feasibility and frequency, we decided at 2 samples per week. But to use our resources in the right way, we had to make some compromises. We only ship those samples once a week. We collect the 2 samples, ask the operator to store them, so that this cuts down our shipping cost, our lab processing cost by half, so that because we only ship once a week and process them once a week. We also, to have long-term sustainability, we started paying them, like, having a stipend policy and various things, because yes, the first year was volunteered, but after that, I think it's important having just one person running the whole thing. We needed to give them some support or some encouragement that can keep them going, because without the wastewater facilities, there is no wastewater surveillance system, and it was important for us to actually cater that. Yeah, so in a nutshell, that's how we built it. Also, one more thing I forgot to mention. So we also have a site right from the start, we monitor our airport, because that is like, it's we have like more than 5 million enplanements every year in this airport. So a lot of traffic goes in and out. And sometimes the new variants, especially with the SARS-CoV-2, that is the only genomic surveillance we used to do at first. So with the new variants, we used to pick them up sometimes at the airport. So we do have that, and we currently monitor for SARS-CoV-2, influenza A, influenza B, RSV, B subtype for H1, H3, H5, and planning to expand this soon to norovirus and EBD68. And measles is on our mind with the things going on right now. But that's how we ended up building the surveillance system. Thank you.
Okay. Um, Hi, my presentation is much shorter, more visuals and maps on what we've done in Houston. Um, We are in a unique position as a large city where we have many wastewater treatment plants that are all run by one utility partner, Houston Public Works. They are part of the city of Houston. Like their emails populate in my Outlook. It's not hard to connect with them. And they collect their samples anyway and collect them in one site. So we just have to go to that one treatment plant to get all of our 39 wastewater treatment plants. And so I wanted to touch on how we built this both temporally and spatially. For temporally, we deliver these samples to the labs. We have two separate labs. We're a big city, but we're still just a local public health department, and it is not feasible for us to do it more than once a week. Like our system just isn't in place to process that many samples. So we do sampling once a week. And in that way, we can cover more ground. So these sample sites were set up by the end of December 2020. We have dropped a few, but everything was in place. Both the treatment plants, lift stations, and manholes were in place by December 2020. We really hit the ground running with a lot of financial support from COVID funds and a lot of interest from health department leadership from the very beginning that wastewater could be interesting. So we actually had wastewater treatment plants and I believe congregate living facilities, manholes like setting up at the same time. And then the health department was like, this is great, let's get it in schools. Like we have the money available to buy more samplers, let's get it at schools. So for spatially though, we sort of have our manhole outreach and then our wastewater treatment plants like information. And the treatment plants kind of, a lot of them match each other. There isn't too much difference across the city. So in all of our right sizing conversations, and we've all talked about, and we have, oh, next slide. I'm trying to do next slide. We have gone to pooled samples, and this allows us to still cover the entire city as we cover about 98% of Houston's population with this. And the holes that you see in the map, if you're looking that closely, they're not part of City of Houston. And we have decided to go from 36 or 39 wastewater treatment plants that became 38 because one got demolished and diverted, that now has become 36 to 15 samples. This was done with, this selection process was done with help from Bryce, from Dr. Enzer, the stats lead on our program. And we selected 5 wastewater treatment plants that will not be pooled. They are still singular sites. And then the other 31 are pooled into 10 samples based on, all the work that she did. And then 2 wastewater treatment plants were simply drops. They were really inconsistent and covered 600 people and 2,500 people. So next slide. The Stadler Lab has developed, piloted and validated a long list of assays, but this is what's part of the health department's actual routine monitoring. This is the the targets that we monitor on a routine basis at the certain levels. And you'll notice sort of at the bottom of wastewater treatment plant that some of them, it's one site. For H5, we're only doing influenza A positive samples. And then for West Nile this year, we just started seasonal. And part of that is around just resource constraints, how to really optimize being able to have all these wonderful assays, but only be able to run so many samples a week. And then we have a sentinel site for Mpox, and you'll see that that's the only place that we're running Mpox testing on a weekly routine process. And then the next slide, wanted to get into, the last ones just go over sort of our, kind of like Colorado, y'all can like scale up and you've got your sentinel sites. We have one sentinel site. We have the Mpox sentinel site. If there's a detection there, we scale up to all the pooled samples. And then if there hasn't been a detection for 4 weeks, we go back down to just monitoring that sentinel site. And this, of course, can be turned on and off if we see fit. If, when Clade 1 was coming out and we all got Mpox money for funding, we could turn it on much sooner before there was an Mpox detection. And so the next slide looks at, for measles, prior to having a measles detection and a measles case in Houston, we were all set. We worked with our epi and we said, well, we can't just do measles everywhere at every site. Let's just pick a singular site. This wasn't sentinel in the sense that there wasn't as much information on picking that this was going to be representative of measles in Houston, but it was a singular site near a hospital that our epi was concerned about. And the idea was that we would do routine sampling at the singular site and follow a similar protocol as with Mpox, where we could turn on to every pooled sample and every manhole sample if we so needed. And this, of course, is now that we do routine measles monitoring at every pooled site, and then we can turn on to manhole if we need. And so we turned on to include the manhole sampling when we had that measles detection back in February, and it's now turned off. And then the last slide is how this all works when we have pooled sampling. Do we lose the granularity of wastewater treatment plants? We do in terms of timing. We're not as quick to find out exactly which wastewater treatment plant had that measles detection if it wasn't a pooled sample, but we hold on to the individual samples from the wastewater treatment plants, and should there be a detection or an inconclusive of measles in a pooled sample, we run all the individual sites in that pooled sample along with the pooled sample again to get confirmation. And that's it.
All right. Hi, everyone. My name is Angela Rabe. I'm a wastewater epi as well as the COE coordinator for our California Department of Public Health team. I also don't have a formal presentation, but I do have a couple of reference slides, just kind of background as I'm talking about kind of an overview of our program here in California. So in California, our program got started in late 2020 with an ELC grant to support piloting wastewater surveillance like many for SARS-CoV-2. At the time, we partnered with the State Water Resources Control Board, which is the regulatory agency here in California that oversees discharge of effluent from wastewater treatment plants. We also partnered with 6 of California's largest wastewater treatment plants for this pilot program. These 6 wastewater treatment plants were some of California's largest wastewater treatment plants and were located in some of our more metropolitan and densely populated regions of California. That pilot year of our program was really instrumental for laying the groundwork and foundation for what wastewater surveillance would become in California. And I think it was really pivotal for our team to be able to generate this data and use this data to make the case to our department within public health of how valuable wastewater surveillance could be for COVID and informing the COVID-19 pandemic. So because of that pilot, we were able to expand our monitoring and bring wastewater surveillance in-house to our state drinking water and radiation lab and expand our program. Over the past couple of years, our program has gone through a couple of different waves or iterations of expansion. And what site selection looks like today for California looks a lot different than it did back in 2021. And we've gone through a couple of different waves of what that's looked like. And I'm sure we'll go into more about kind of our considerations for site selection in California. But broadly speaking, over the past couple of years, we've tried to keep in mind maintaining broad coverage of California's population. So trying to ensure that we're capturing the majority of California while also trying to balance having both demographic and geographic equity across California and across our different regions. So today, our program, which we refer to as the California Surveillance of Wastewaters or Cal Sewers Network, covers between 80 and 90 sites. We have a handful of upstream manhole monitoring sampling locations in neighborhoods of California. We cover approximately 24 million Californians in 39 out of our 58 counties, which works out to be about 60% of California's population covered by wastewater surveillance. I think it's important to note that our California Surveillance of Wastewaters network is just that. It is a network of contributing partners. So we rely on data that's coming in from several different wastewater monitoring programs across California. So that includes sites that participate in our CDPH state laboratory, sites that participate in wastewater scan, as well as the CDC News commercial contract, and sites that also participate in some of our local county health run programs. So some of our counties in California have been working to establish their own wastewater surveillance programs by bringing wastewater analysis either in-house or establishing contracts with commercial laboratories to expand their county's surveillance programs. So next slide. Some of our kind of future considerations when we think about our surveillance network in California is how do we consider, not only just California as a whole, but how do we look at our surveillance system at different geographical scales? This includes looking at the county level or breaking it out by regions. So in California, we use what we call our regional public health officer regions, or RPHOs, and we have 6 of those in California. We break up the state like this not only for evaluating our surveillance system, but also to be able to generate trends and levels that are based on regional data so that we can share data with counties and regions that may not necessarily have wastewater surveillance data, but then can refer back to their region to get a better or a broad picture of what's going on within kind of their surrounding counties. Most of the sites in our program provide samples 3 times a week. And we do year-round testing for each of the targets that we're monitoring for. So right now that includes SARS-CoV-2, influenza, H5 subtyping, RSV, as well as Mpox, clade 2, and soon clade 1. While some of these pathogens do have seasonal patterns, we've found that having continuous year-round data has been really valuable for our team of epidemiologists to establish baselines, which we can then use to create levels and metrics. It also definitely streamlines and simplifies lab operations for our lab team when they're doing continuous testing throughout the year. There are some downfalls that come with this, right? So we don't necessarily have as much flexibility to be able to bring on targets or change targets when we're doing year-round testing if our plate's full. But we work with our laboratory to kind of try to flex and adapt our program as needed to meet changing our public health needs. A couple of key lessons that I think our team has learned over the past couple of years when we think about our surveillance system and our level of surveillance. The first of which is that a one-size-fits-all approach doesn't always work. And I think that applies from jurisdiction to jurisdiction, but I also think that applies when we're talking about what pathogen we're monitoring for. Your surveillance system for COVID may have worked great for COVID, but it may not apply directly when we're talking about a new pathogen like H5, right? Our surveillance system was built with COVID in mind, not with dairy industries in mind. So it really depends on what pathogen you're talking about when you're considering, the effectiveness of your surveillance system. And then I think another key lesson that our program has learned over the past couple of years is that you really have to keep in mind your surveillance goals when you're thinking about your surveillance system and setting up your surveillance system. Is the goal of your program to detect, a new rare pathogen or the first case within one of your communities of a rare pathogen like Mpox or something that's less expected? Or is the goal of your surveillance system really to track changing trends of more expected pathogens like COVID and flu that we see more continuously throughout the year? So I think both of those kind of considerations are important when you're thinking about your surveillance system and setting up your surveillance system. And that's it.
All right. Thank you to all our presenters for your presentations. So we have a great representation of panelists from across the nation. And I wanted to delve into what is unique about surveillance in your area. And we can start with Rebecca.
It's now screen. Thank you. I think something that is unique about Houston is that we are a local public health department, and so we can really get into the schools, for example. The health department already has programs that are involved in the schools. We're in the schools for a dental program and a vision program, and so that helped us get in COVID to work on those relationships and get to 45, it was at the time like 50 schools, and having that. And now that is part of our school virus alert program. We send text and email alerts to the school communities when flu, RSV, or COVID is detected in their school's wastewater.
I think for Nebraska, it is more about the way, what I just talked about, the way we structured our program, which gave us a strong foundation. Like, I know now we have things set in place, and if we want to test any targets, we can. We have a good population coverage. We have great relationships with the local health departments. That is something we worked over the years to build utilities, local health departments, and the state health department to work as one unit. We really have that seamless communication right now. I think that relationship is what we built. Because today I was talking to someone and I was like, okay, that is not the case everywhere. And that is what I realized. I thought, oh, it's the same thing everywhere, but it's not. So I'm really glad we have that. Because ultimately this data has to be all of us talk about or get asked about. One constant question is, how are you using the data? How is the data is actionable? It's not a black and white answer, but most of this happens at the local level, and we need to keep them in the loop and make sure the data gets, used. Yeah.
I think in North Carolina, one of the things that we uniquely bring to the table is, and I think a lot of our southeastern states are in this same situation in our region. We have a lot of rural areas in southeastern North Carolina. So I don't know that we have quite as much like flexibility in like reducing our number of sites, for example. In a lot of other states, I'm always pointing to Utah and picking on them a little bit because they can cover like 98% of their population with wastewater surveillance. And that would be lovely to do for us in North Carolina, but we have a lot of folks that are on private septic, about 50% of our population. So we just have a very unique situation where we have to think about, okay, how are we able to use wastewater in some of these areas that we do have people either traveling there for work or their kids go to school there, but then can we capture them using kind of the existing areas that we have? But how do we also think about, other folks that don't have access or aren't on the system? So we don't quite, I think, have as much flexibility with like a reduction in sites. So we just really have to be understanding of that and think about the equity of who we're representing in our network.
Yeah, and I think for California, our wastewater surveillance system has been uniquely shaped by our state's sheer size and diversity, and also our decentralized public health infrastructure. So in California, we have nearly 40 million residents, and we actually have over 1,000 active wastewater treatment plants in California, which I think is pretty unique to our situation in California. When we talk about things like right sizing, I think it's been really invaluable for us to consider, as I mentioned, not just looking at our surveillance system at a whole for the state, but also looking at these different geographic levels. And doing so has really enabled us to kind of pick out where we have wastewater surveillance gaps and try to fill those gaps with additional sites. Something else that's maybe a little bit unique to our surveillance system in California is the range of populations that our sites cover. So we have wastewater surveillance sites that cover anywhere between a couple thousand people up to, 3 or 4 million people covered by one wastewater treatment plant. So when we're talking about data aggregation or, comparing data or trends across sites, I think that's something that we really have to keep into consideration is just really how wide our ranges of population sites for our sites in our program.
Awesome. Thank y'all so much. And speaking of the levels of surveillance, how do y'all evaluate the effectiveness of surveillance at different levels? And whoever's ready can go first.
I can go first. Okay, I think when we're talking about the effectiveness of a surveillance system, it's really important to keep in mind what pathogen you're talking about and how effective your surveillance system might be for that pathogen. Our teams definitely looked at, correlations to see if we have lead times for wastewater surveillance compared to other data. We've also looked at trend stability over time. But yeah, I think it depends on the pathogen that you're talking about. More than kind of these analytical approaches is also some of these use cases of like anecdotal examples of how wastewater surveillance has been informative. And I think we can learn a lot from these in addition to some of these more analytical approaches to evaluate effectiveness, right? So being able to say that wastewater was able to pick up a MPOX case or a cluster of cases is really invaluable and almost just as important when you're talking about the effectiveness of your surveillance system as kind of an additive.
We talk a lot about manhole testing or sampling in Houston, and I mentioned lift stations. You'll notice they didn't really make it further into the slides. In our experience is like just having the data be worth sampling. The lift stations were very hard to sample. They're very deep, and you have to get Public Works to come and open the gate for you for our health department employees, and it just wasn't that information gained was not worth the sampler's time. Yeah.
For us in Nebraska, yes, initially there was a lot of pressure to prove how, if this data is actually working the way it has to work. So we did some correlation studies initially with all our targets, and we are continuing to do that as we onboard new pathogens. But so there are different levels of one thing. Yes, the analytical is the wastewater tracking the trends well, like compared to clinical surveillance metrics. The second thing is, are we giving enough population coverage? So one thing we have is a good rural communities or good population coverage in the rural communities, which is actually what we lack in some of the clinical metrics. We really don't have that level of data. And especially like, for example, some of the local health departments reach out sometimes if there is a delay. You all know in the wastewater world that things break a lot. There are delays a lot. There are a lot of delays, and sometimes whenever there is a delay in the report, sometimes our local health departments reach out asking. We had like a couple of instances that like, okay, we need to make some decisions. Like it might be, something putting out in the social media or vaccinations campaigns or testing, increasing the testing. So they try to make those decisions. And most of these local departments are actually rural because they are the ones who rely more on this data. The urban sites, I know one of our, Lincoln is local health department is over here, but they have different metrics. For example, if we think a disease as a puzzle, they have different pieces of puzzle for the urban sites, but sometimes for the rural sites, wastewater is the only puzzle available and they have to make the best decisions. So that's how like those anecdotal experiences. And I got a similar call like, Ariel got like, hey, where is your report? This was from the public. We have an immunocompromised person. So hearing these things really makes, I feel when things break, actually it's good. I know who are using the data. So
Yeah, everyone here has already made a lot of great points that I think we agree with in North Carolina. One of the things I'll just add is also doing these like formal lead lag analysis or something like that for correlations with targets. I think one of the pieces I always try to bring to the table is no surveillance system is perfect. When we're comparing to like clinical data sources, I actually get really excited when I see wastewater picking up something that we didn't see in our clinical specimens, right? Because to me, it shows that these things together can patchwork and give us visibility in areas that we might not have seen, whether we're talking about geographic areas we may have not seen, or we're talking about a new sequence strain, like from a genomic surveillance perspective. So I'm actually really happy to see some of these things, like what Kirsten was talking about with hepatitis A earlier, where we're picking up things in wastewater with sequencing where we're not seeing that in the clinical specimens. Those are really good opportunities, and I think show the value and the effectiveness of the system to be really filling in those gaps, because we know that as well as we try to design our public health systems, right, they are reliant on people seeking care. They're reliant on healthcare, people having access. And it's something that we struggle with in North Carolina, to have a lot of people have access to care. So just if wastewater can help fill those gaps, that's something that we're really, we see as a lot of value to, evaluate like our effectiveness.
All right, at this time, I'm gonna open the floor to the audience to ask some question. Cody, do I need to pass around the mic? All right, we got a mic. All right. Awesome. All right, yeah, if anybody wants to, go ahead. Ricky?
Hey, I am Prakit Singh. I'm the fellow from Hawaii Department of Health. I want to ask question to the Houston team. So I really like the idea of decision-making step of turning off and turning on to sample more sites, because the thing that I'm thinking about is in the area that we have the surveillance at the city level and also the sub-city, like single facility, particularly the nursing home, it will cause the workload to everyone involved, like the wastewater team, the epidemiology team, and also the care facility people as well. So I want to ask Houston team to share maybe more stories during the process of developing these decision making. Does it help? Does it help with does it help reduce the hesitancy of facility people to get on board? And also, does it help with sustainability of the wastewater testing program?
It certainly helps with the sustainability of the wastewater testing program. The 4 weeks of no detects to turn off is really based on the MPOX, but we saw an MPOX when we just did MPOX at every site all the time around wastewater treatment plants. And we found that from the first outbreak in wastewater monitoring, those happened about at the same time. We found 4 weeks was reasonable to turn it on after not having a detect. And we've sort of brought that over for our other turning on and turning off monitoring. I do want to just point out, like you mentioned, Houston is in a position where we're turning on sites, and those happen to be downstream manholes, versus somewhere like Colorado who turns on, who like still has a turn on process. It just happens to be at a larger level. I can't speak to the hesitant, like bringing on nursing homes, because we did it all in COVID. Like we brought in every nursing home sampling site we brought on during COVID when the older population was susceptible. Like it was very easy in a sense to get in the door when testing hardly existed. And so we benefited from that for sure. But it could be used, potentially could be used as you're trying to onboard ones to say like, look, we're not going to be sampling at all times. And then the last one is to Angela's point about like it's pathogen dependent, like non-detects are still useful information. And so if it's something that you would like to know is not there at all times, like having it turned on maybe should Seora's sampling ever, take off.
All right, we have a two-part question for Nebraska from Colleen. So for some of the counties not covered, was the reason more the logistics for rural utilities, or were there other reasons that they couldn't participate? And then how did you work out logistically your stipends? It has been challenging to get utilities paid or make it worth it for legal and accounting for us.
Yeah. So for the first part of the question, for the jurisdictions that we don't have a site yet, as I said, with some sites it's easy to make connections and onboard the sites, but with some people, with some of the wastewater treatment plants, as I said, it's just one site, it's one person who is doing it. We did reach out to the those jurisdictions, some of the sites in the jurisdictions, but we haven't had luck. So what we do is reach out to the local health department. We try, because we are they don't know who we are. They don't know our faces. They don't have any relationship with us. But with the locals, they do have a relationship. So what we are trying to do is ask the local health departments to reach out to them, make a connection through them and onboard the site. We recently were successful in one of our Southwest local health department to do that. The local health department made the connection and we onboarded that site. So we plan on doing that with the other ones too. It's really difficult with some of the sites to get through them. And on the second part of the question, on the stipend policies. So in our first year, it was voluntary participation. But later on, we realized that it is important that we value their time and energy that goes into the sampling, given how busy they are. And with our urban sites, we don't have, even if we don't pay the stipends, I know they will be participating. But with our rural sites, we were really concerned of losing them eventually. So before that happened, we tried to so our stipend plan changed over the time. Initially, we didn't want it to complicate it. One more thing with the wastewater facilities, especially in rural areas, is they're very busy. They don't like sometimes too much communication. Do it in the emails and like as much as possible, but we don't like to bug them because they're already busy. So initially we just said, hey, we'll just pay you for participation, we'll pay us flat stipend money. We didn't account for if they were collecting 2 samples. We just tried to see if they were at least participating for more than 6 months in that 1-year period. And as a goodwill, we did give a flat stipends to all the people who participated. We did that for 2 years, but now we want to make slowly, subtly more accountable. So we changed it to per sample stipend policy. And to answer the question on the legal stuff, I think that's what the question was, right? How we worked out the legally, okay. So we understood if we had to do the contracts, I know there were sub-awards and all these stuff, it'll take years or months or like a year to get those things out. So we used a shortcut. So we have so we have different partners, like we partner with UNL, Civil and Environmental Engineering team to help onboard these sites, to set up auto samplers if they need it, and all those stuff related to the sampling and logistics. So we already have that contract with the university, and we amended that contract. We gave the money to the university, and it's for the university, it's just giving a check out, so we paid it through the university. So because that was the quicker option for us, because we couldn't do like 17 to 20 sub-awards for that and go on for years, not knowing when we will really, be successful in completing those things. So yeah, our university really helped us. That relationship really helped us to do that. Yeah.
And one more part to that question. Does the stipend go to the plant or the sampler?
Can you repeat that? I'm sorry.
Does the stipend go to the plant or the sampler? And Colleen, I don't know if you want to come off mute and expand on that question.
Can
or
I know
clarify.
what you mean by sampler? The person?
The person sampling,
No, it
sorry.
obviously goes to the, oh, okay, I'm sorry. Okay, thank you. No, it is to the wastewater facility. I mean, we cannot pay that. I was confused. Sorry, we do send it to the wastewater facility. I mean, they have to give a couple of documents. That's it. It's not too much of ask from them, and yeah, it directly goes to the wastewater treatment plant or whoever they give the information about. Like, pretty much. We are not specific on that.
Hi, Anil Mangla from the South Nevada Health District. So my question is for you, Stan. What is your rationale in doing wastewater surveillance at the hospital? And what's the added value? Because when I think of that, right, when I think of that question, or, the slides that I saw, from an epidemiologic point of view, the highest risk population for measles would be under 18. So it would be better to do surveillance in schools to be proactive rather than a hospital, right? So I just want to know what's the added value.
The hospital and the area around that hospital serves that community is in the wastewater treatment plant that is monitored for measles. So we're not monitoring just a hospital.
Okay.
It's like we're monitoring, like we've identified the community based on that.
Right.
And it would be great to be monitoring measles at 45 schools, but
Right.
we can't bring that on for every week.
Okay, thank you.
Yeah, yeah.
Okay, one more question about stipends. How would you control for samples that get contaminated or aren't properly collected if this happens? Do you have conditions on sample quality for the stipends?
So yes, we do have some language in our policy. So we prefer a 24-hour composite sample as much as possible. I mean, majority of it is 24-hour composite sample, but I know there are situations where auto sampler breaks, or sometimes the operator forgets to actually switch on, time the auto sampler. So in those situations, we do accept grab samples, but we have seen a lot of issues with grab samples. Sometimes there is we try to avoid it as much as possible, but we can't. That's what we try to be flexible with them. We don't want to be in an assertive tone. Okay, this is what we want, and we'll only pay you if you give that. I think that is really wrong on our part, because they're doing this, taking the time out, and we try to not be. I mean, if some site is really doing all grab samples or something, which we have, not encountered so far, it'll only be like maybe every 2 or 3 months there will be one grab sample, and which is okay to us. But we did include the language that we need a 24-hour composite sample, and they have to be stored, packed in certain conditions. So far, we have been really touch wood, it was good that not a huge problems on how they pack or they send the samples or anything. There were not a lot of issues. We did give them good, we made a video to them, like a YouTube video, and gave the, how to actually pack it, and all the instructions. We made give them all the supplies and make it as easy as possible, even as small as plaster or anything. We give them all the supplies they need for the packing. So we try to make as easy as possible for them.
All right, and I think we have one final question.
Thank you. My question's, I guess, for Ariel, but welcome comments from anybody else on the panel. It pertains to detecting pathogens in wastewater that we don't see clinically, or strains that we don't see clinically, and vice versa. So as you mentioned, this is a good thing, because we're finding a lot of diversity that we don't see in clinical samples, and it's giving us a lot more information on evolution of viruses and pathogens that we otherwise don't see. One area that I think it's caused actual confusion and questioned the utility of wastewater even is actually Mpox, because in New York State, and particularly in New York City, where there was a lot more Mpox, we were seeing wastewater positive when there were no clinical cases, and vice versa. And so for a number of, and we're not the only ones, And a number of places have stopped testing for mpox for that reason. They did not know how to interpret the data. And, you know, there are many reasons why this can happen. People are moving through the area and they're contaminating the wastewater with their deposits, and now they're not there. And so you don't see the case there. Or people, as one of my epidemiologists told me recently, I live in one county, I work in another county, and I play golf 3 times a week in a third county. So I am contaminating the water in 3 counties with whatever I shared. So your perspective on what you do in these situations when it doesn't line up in either direction, clinical cases to wastewater or wastewater positive to clinical cases, and how do you deal with those situations where you have no way of assessing the relevance and utility of what it is you're detecting?
No, I think you highlighted a lot of the context of this really well in framing up that question. I think for us in North Carolina, impacts has been certainly a challenge because of exactly that situation. You have all of the possible permutations. You have wastewater detections without clinical cases. You have wastewater detections that are aligned pretty well with clinical cases in terms of timing of those detections and like symptom onset of the person, right? Because we can geocode those. And then we also have the scenario where we have clinical cases or, you know, wastewater detections and no clinical cases. So I think I said those all correctly, but you all understand what I'm saying. So we have all of those different permutations. And I think for us in the situation, for specifically when we're getting wastewater detections and not seeing clinical cases, the best thing, because we're a decentralized state, of how we've been using the data has been to talk to our local health departments about how they want to handle it. And all of them have been slightly different in that approach. I'll give one example, which was in Guilford County, where we kept seeing mpox detections in wastewater, but we were not finding clinical cases for whatever reason. And I don't think I typically don't go on to the side.
Yeah, if you could just send me the one that does and then maybe flag.
Yeah, I'll flag those. Okay.
You want a little couple?
Oh boy.
Yeah, I've got some. Thank you.
We might be part of a phone call right now. Okay, can you all hear me? Okay. Slight interruption, technical difficulties. So the situation in Guilford County where we just kept seeing wastewater detections pop up, and this was for mpox clade 1 or mpox clade 2, I'm sorry. I don't think it's reasonable for me to say that those are not correct, right? The DNA doesn't really lie. And I think that's important for us to say. One isn't correct or incorrect. I think it's just more information. And the way that we handled that in Guilford County and the way that they wanted to handle it was doing additional notification to the hospitals. So basically doing a healthcare provider memo and saying, we have one type of surveillance for wastewater specifically, that's giving us indication that there's infections happening in the community. Can you all add mpox? Remember to add mpox to the STI differential when you're asking about screening, right? So that those are things that we can do that don't necessarily cause harm to the population or to added cost. It's just something that we can do kind of proactively. So I think thinking about what that action can potentially be. They also were doing a lot of work with apps, like partnering with apps, like dating apps. So they had also talked about like doing a notification within those dating apps that, hey, we have some indication of infections in the community. So I think thinking about like what that action is, and if it's a proactive action that isn't necessarily causing harm, I think using that information as just additional source of data, right, to tell us that we might have infections that are happening in the community. So that's one example of how we've been using it. I don't know that I would go as far as not testing because because the information isn't totally aligning with clinical cases. That to me, again, is one of the values that we are bringing to the table.
Awesome. Well, I'd like to thank our panel for all their insight and all the work they've been doing and continue to do. Let's give them a round of applause.